All right. Hi again. Okay. So ACGME requirements for family medicine. So it's been a great discussion. We've kind of touched on a lot of things. A lot of things have overlap here. I'm going to go a little bit more into a little bit more of the details of what the requirements for family medicine are. So one thing that you heard mentioned earlier today are common program requirements. So all programs, no matter what they are, whether they're invasive cardiology programs, orthopedic programs, or family medicine programs, all have to comply with what are called common program requirements. So the interesting thing is that common program requirements are actually just undergone a cycle of revision. So there were a number of things that were implemented that programs now have to comply to or adhere to, and they're really focusing more on the work environment for the residents. Is really something that kind of a theme that's really been highlighted in a lot of these changes. For the first time, like ever, although for us this is kind of second nature, it's actually stated in the common program requirements that the program has to engage in retaining a diverse and inclusive workforce of residents, faculty, and staff. I'll get my glasses here because I can't read my own slides. Okay. And like you've heard mentioned already, they have to have access to food, safe sleep facilities. In July of 2020, you're going to be obligated to make sure that they have places to do lactation, so that you have like a room for new moms to be able to breastfeed, as well as you would think that this would be kind of obvious already, but I guess in the requirements before there wasn't a specific thing about being ADA compliant, so now it is. You've heard already, program director has to be approved by the GMEC and then approved by the review committee. One of the big changes that is in the common program requirements now is that the PD has to be there for an adequate length of time to maintain continuity of leadership and program stability. That is not something that was actually there before, although everybody who does this kind of work kind of knows this is second nature. The one thing that is specifically outlined in there is that 20% of the program director's time must be non-clinical time for the administration of the program. So this was a requirement that was present in many other individual specialty programs, various durations, 20, 50, 70%. But now for the first time, it's recognized as a common program requirement. And then faculty development. It's always said that there has to be faculty development annually, but now they're telling you what you need to do faculty development in. And one of these things is well-being. So faculty need to really know what well-being for residents even means. And so that's something that's now in the common program requirements. So the review committee for family medicine, we've kind of discussed a lot of this already. They review programs, they monitor for adherence for common and the specialty of family medicine. They determine accreditation. They are the ones that typically are proposing any changes to the program requirements. Talk about policy relevant to the specialty practice of family medicine, and then they make these recommendations to the larger ACGME review committee. So the review process for family medicine. So they've moved from the kind of traditional model where most of the physicians in the room went through, where they kind of went through this big rigmarole every 3 to 5 years that felt like a JCO site visit. So now it's really moved more toward a model of kind of advising on process. And so now you make an annual submission as a program every year. This is the web ADS portal that Kiki was talking about earlier, and they'll send you something back that says, hey, we want more clarification on XYZ that you submitted on your portal, and then you'll get a clandestine email that will just kind of arrive randomly saying, okay, yeah, you're accredited. you'll get a letter in 60 days. No other fanfare. So that can be both good and bad. If the accreditation decision is a good one, then that's great. If it's like, oh, your proposed probation or something, then you kind of lie in anxiety for 60 days until that comes. But most of the time, it's a very streamlined process now. And then they also take time to really recognize the highlights of your program. So if you have things that you're doing with the training program that you're particularly proud of, you should put them in your report to WebAds. Because then when you get your accreditation letter, sometimes you'll even get a notation there that the review committee is recognizing that as best practice, and may even highlight that at board level meetings for future curriculum changes. So for sure, if you guys are doing that's like totally awesome that you really want to share with the review committee, feel free to do that. Every 10 years now, we're in this program model now where every 10 years there is a site visit. The program submits a self-study based on their review of any existing citations, challenges. Basically, you do a SWOT analysis of your program. And you submit that report. You have to prepare that report, submit that to the ACGME, undergoes an extensive review, and then they give you a new accreditation decision. So that's really kind of more of a self-report that you do every 10 years. Only the first few programs in emergency medicine and I think internal medicine are going through this process now. No family medicine program has had to do this yet. So the top citations in family medicine, this is a little bit dated, but they're pretty much the same today. So evaluation, performance on board exams. Bottom line is if residents don't pass the board exam, and now it's even if they don't pass like beyond the 25th percentile, that could result in a citation. Responsibility of the faculty. So this is a particular challenge in small programs. Faculty have to practice the full scope of family medicine. You have to have adequate role modeling of your faculty. That means you have to have faculty that take care of inpatient pediatrics. You have to have faculty that deliver babies. You have to have faculty that see adults in the hospital. You have to have certain procedures that residents are trained to do in the inpatient and outpatient setting. So those, like if you don't have faculty that they either can, people that can partner with you or that are already on your staff, that's a potential citation. Board certification is really non-negotiable. Everybody who trains your residents must be board certified, with very, very few exceptions where you have to really demonstrate that their training and experience is equivalent to board certification, which is becoming an increasingly hard thing to try and argue. Curricular development, so this is like, well, the residents only get like, 2 weeks of musculoskeletal medicine training. Well, that's not adequate, so you get a citation. There's different minimum requirements in terms of hours or months of training that residents have to have in order to meet minimum requirements. And then scholarly activities. If you're in a program that doesn't really have a lot of resources or ability to allow residents to learn about how to develop and critically review the literature, critically review evidence, and develop their own research projects, QI projects, then usually that earns you a citation. Areas of improvement are kind of like a level 2 violation. So not quite egregious enough that that it's giving you a official citation, but there are areas that they've identified that they really would like you to work on. Board passage rate, again, is one of them. So it's one of these things, again, if all your residents, maybe they're passing, but they're all barely passing, that might get you one of these. Okay? Faculty scholarly activity. Well, again, role modeling. Faculty have to publish, write papers, do presentations, and the bar is really not that high. For family physician faculty, they have to do two things at a regional or national level every 5 years. It's not a particularly high bar if you're core faculty. Resident and faculty survey. So this is the resident and surveys that are specifically sent to residents and core faculty by the ACGME. It is considered a survey that is not available to you except in aggregates. And the ACGME looks at this and wants to see that what the residents and faculty are reporting are in fact what the program is officially reporting. And so it's never pleasant when what the residents say about the program doesn't really agree with what you think is going on with the program. So again, this just, identifies an opportunity to really kind of improve that communication. And then inpatient data, this typically refers to not seeing enough of a particular type of hospital-based care, hospital-based patient. So love letters. So I call these love letters because they really are love letters. So they'll send you a letter every year, kind of talking what describing what I mentioned. So they'll confirm your accreditation status, they'll list your citations, areas of improvement, and then they'll indicate if they need any additional information needed. When you actually get that letter, there'll be like a section. It's called a very specific format. At the bottom, there'll be like other comments. It'll be like the review committee, recognized the program has done great work working in, women's shelters and creates a, fantastic community engagement experience for the residents, which will be shared at the ACGME board meetings. Great. Nice to post that one on the wall, Okay, so the actual requirements. So these are specific examples. It's not an extensive list. The extensive list is on the ACGME website. We'll just go through some of the specific things that probably more related to context here. So there has to be at least one dedicated site, clinic site, to serve as the foundation for educating residents. If you do use multiple sites, so I know some of you are exploring the continuity clinic model, they all have to meet the same criteria as the first site. And overall, the residents must get the broad spectrum of experience. So it's kind of going to what Kiki mentioned earlier. Some programs may look to expand to another site, say, for example, if their primary site doesn't have enough kids or doesn't have enough geriatrics, or they have no women. And so this is a model that sometimes programs will use to also expand. The ratio of residents to faculty preceptors must not exceed 4:1. That's kind of in the guideline. I will tell you just from a practical teaching standpoint, 4:1 is too much. I can't precept, 40 patients in an afternoon. It's not safe, nor do they get good teaching, nor do they get good care. So usually kind of a safe ratio is kind of 2 to 3 to 1 in terms of precepting residents. But in a pinch, somebody calls in sick, you don't have a replacement, 4:1 is the limit. Have to have behavioral health faculty. Does not need to be a psychologist or psychiatrist. It can be a family physician or other provider that provides this training, but there has to be somebody who's identified as that in that role. Yeah, question?
So for a continuity clinic,
yes.
If it's more for ambulatory care as an outpatient, and supposing that accuracy will not do delivery, so the faculty, if there's a faculty must provide care to the patient, adults, children, and delivery.
Right, so we're just talking about this. So the faculty that are in the clinic don't have to be the ones that do the deliveries, but the program must have faculty that do deliveries. The program must have people that do all of those things. So if the training program has family physicians that are hospitalists, great. And they're academic hospitalists, and they train all the residents, and they take all the patients from all the faculty practices, and that's fine. They just have to have somebody on the faculty that does all of those roles. They also have to have time to do direct patient care. So, in this audience, that would seem to go without saying, but in some academic programs, there's still a few programs where some faculty, they do nothing without residents. And so that is something that is being recognized as something that, hey, you actually do have to have a patient panel, even if you're 20% time. And then, of course, like I saw before, you have to be board certified. There has to be one core faculty member for every 6 residents. I believe that's kind of more of the standard mix for most programs. But and that does not include the program director. So if you have a program of 4 residents per year, which is the minimum size, once you're fully grown out and you have 12 residents, you have the program director plus 2 core faculty, 1 per 6. The sponsoring institution has to provide you a full-time residency coordinator. So that does mean full-time. It's not somebody who, kind of does this on the side, whose other job is, some other administrative role. Talk about the minimum size. So there are certain minimum specific quantitative experiences in hospital, maternity, pediatric, ambulatory care, emergency medicine, and different specialty care areas. So it's pretty much a foregone conclusion that most programs don't have all of this in one place. So it does really kind of bring up the issue again of partnering with other institutions to provide that. And for family medicine, I won't go into the whole list. There's a fairly extensive one. It's like a month of this kind of experience, 2 months of this kind of experience, 4 months of this kind of experience. 750 adult inpatients, 250 pediatric inpatients, the list goes on. You also have to have experience in a long-term care facility over 24 months. So that's something that's fairly unique to family medicine. There needs to be something there's some kind of longitudinal experience in kind of a nursing home or long-term care facility setting where the average number of patients the resident needs to take care of is 2 at a time throughout that period. They have to be trained on how to do procedures, both hospital and ambulatory based. And this is something that's kind of a lot of programs struggle with, particularly programs at larger institutions too, where the residents must participate at least at some level with the clinic side in their regular kind of business operations. And so a lot of places do this in a lot of different ways. The way we do this is we have a clinic steering committee. So the steering committee typically includes some of the clinic leadership, the clinic manager, medical director, and then of course the residents. And the idea there is to kind of review and discuss policies and procedures related to the clinic. That may be where you share with the residents their performance metrics, their Prescani scores, whatever your site uses to evaluate performance. And you want the residents, in fact, you have to demonstrate that the residents actually participate in this exercise. The idea is that you're preparing them for the reality of practice, which is what we look at this stuff. Scholarly activity is required. Residents have to do 2, at least one of which is a QI project. Most hospital-based training programs do this with some hospital finding like catheter-associated UTIs or central line infections, stuff like that. In our program, all of our QI projects are clinic-based, which I would imagine would be the same for you guys. And then, like I mentioned, faculty have to do something at least every couple of years to for the program to stay accredited. In terms of evaluations, residents need to get some kind of evaluation no more than 3 months apart. So we do semi-annual evaluations, reviewing overall performance of residents, and then they get a monthly rotation evaluation. So they have to get that ongoing feedback. Okay, so changes to the FM requirements. So this was actually under open comment and review until today. This is actually the last day for open comment and review on these changes. These are some of the suggested changes that are planned to take effect in July of this year. So one of the thing that's really been defined is that residents cannot travel more than an hour to anywhere. So if they have to travel more than an hour to a training site, that is not allowable now. It was technically not really allowable before, but a lot of people kind of got around it because there was a mileage versus time requirement before. Now it's just 1 hour. If it takes you an hour, so if you live in this town, you can't get nearly as far as you can go in my town in terms of distance to training sites. And so that's something they're paying attention to, the idea being because of the focus now on resident wellness. They have to be able to access your EMR for their clinic patients from anywhere they are. So preferably from home, but definitely from their clinical sites. So if they have, if their patients are in the continuity clinic at an FQHC and they're seeing patients in the hospital, they have to be able to access the records of that patient from where they are in the hospital. That's new. In the past, it wasn't even required that an EMR system be available, and so long as you had access, you can meet that requirement. Now it's very clear that you have to have access to the EMR from wherever you're at. So that might be a challenge for some sites. Also, residents have to be able to monitor or be able to be responsive to the needs of their patients at their clinic site, even when they're on outside rotation. So if somebody's doing like an inpatient medicine rotation, they still need to be kind of, checking their inbox, refilling the prescriptions, whatever is within the context of the curriculum for that program. That again is also new. The recruitment of a PD. So now they've kind of spelled out a little bit more what the requirements are. So the PD cannot be just some good clinician. So the PD has to be somebody not only who's been faculty for a number of years, but also someone who's been in a leadership role in that faculty. So whether they were a site director for a training site, so like they were the clinical site director for your clinic, or they were like chair of the CCC, help me, the Clinical Competency Committee, thank you, sorry, or the Program Evaluation Committee, where they're actually directly involved with the evaluation of residents on a regular basis, in some kind of leadership role, so that the review committee knows that the program director knows what the hell they're talking about when it comes to leading a program. So that is actually a new specific requirement that's now in there. Brand new is also this, the concept of associate program directors are now required in family medicine. So other programs, I think including internal medicine, does have, and pediatrics do have had a specialty level requirement for associate program directors based on the size of the programs. Now family medicine has joined the party and they're saying that, hey, it's not reasonable for our program director to kind of solo manage a program of 40 residents, they need help. So now there's specific requirements for that. And the reason really for putting this in the program requirements is really to hold the sponsoring institutions accountable for providing this level of support. And then there also a new phrase, which many of us are already doing in existing programs, is really allowing residents to really participate and function as part of an interprofessional team. So that means working with not only your PAs and nurse practitioners, but your social worker, your behavioralists, your MAs, your patient navigators, what have you, and that the residents are part of that that team approach. And so again, for you guys, this aspect is really kind of preaching to the choir, because many of you guys have this kind of systems, these kind of systems and relationships in place already with your patient care. But for a lot of university programs that are kind of, locked into their model, this is something that's being pushed their way as well.
Item.
Yes, ma'am.
Did you respond?
Did I respond?
The comment period.
Did I
Did you
respond
put any comments in?
to? Oh, to this? Yeah. Yeah, I'll get to it. I'll get to it.
Oh, I'm sorry.
I get to it. Yeah.
I was wondering what you
Yeah,
saying.
so our response to this really pertains to this issue of the 20%.
Yeah.
Okay?
Yeah.
So that is a problem because in the new requirements, the prior requirements held that the program director for family medicine programs had to have 70% of their time reserved for basically running the program or being with residents, and that only 20 to 30% of their time could be spent doing direct patient care. With the new requirements, the family medicine RRC has removed that and really kind of allowing it to default to what the common program requirements say, which say that only 20% of your time needs to be reserved. So were I still a program director, I'd probably be a lot more impassioned about this, but it has caused a huge uproar in the professional academic circles on really expecting a program director, because where this comes back to is the funding, right? Yeah. So if the program requirements only say that 20% of a PD's time needs to be funded or is required, then a lot of sponsoring institutions may take the approach as, okay, well, we only need to pay for 20% of your time. That is not going to fly. So there's a huge surge of, I think all the listservs and everything are blowing up with, with the concerns around this. And the RRC has responded, saying they're going to reevaluate that, but that is potentially a fairly significant change to the requirements that would really, quite frankly, undermine a lot of the more staff, the programs that we're funding is at a premium for supporting educational time.
Two things. One, it feels like they are shifting that time requirement to the associate program director.
They are.
Which has no requirements to the position other than a board-certified family physician, right? So that is uncomfortable. And I'll share with the group that, so historically, it's been 70% academic and administration for the program director as protected time. I actually, when budgeting for a brand new program, will put in 70% administration, okay? And I rarely, there's always some pushback, but I say, look, to stand up a brand new program,
you need a little extra time up front.
You can't be saying, okay, now go precept 15 shifts. And inevitably, there's life happens, and this gives you the capacity to have the program director step in and precept, or step in and give a didactic, or step in and be that safety valve.
Right.
So now to get 20%, it's kind of like, well, what bummer?
Yeah,
and they're not going to pay for it. They're not going to pay.
They won't pay for the other time, right? So in our program, under the 70% rule, our residency director, because now granted, we're an established program, we've been doing this for a while. Our residency director has about 40 to 50% time administrative, and the other 20-30% time that's required to be with the residents is typically spent precepting or doing lectures or things like that. So that, under the old rules, was okay. Under the new rules, it does say specifically administration, so not teaching, not patient care, not precepting. So that reserves one piece of it, but certainly for new programs or large programs, that could pose a significant challenge if the program director is expected to do a lot more patient care or a lot more direct patient teaching. So it's hard to know, right? Because it's bureaucracy. But I think that that's probably not going to be the final version. So again, more to follow. the time for submitting comments was over today. There's like a 45-day period, and so we'll kind of see from that. Okay, so kind of in summary here, so again, just a reminder that, no matter where the program is, they're going to need to meet the same basic training requirements. They're going to have to do the same number of hours, same number of experiences that, all these other hospital and university-based programs do. Partnerships are going to be needed to meet at least some of the requirements, with the most obvious ones being training in different subspecialties and hospital-based training. So just to kind of, tell you that this actually is achievable, okay? So, even though it's extensive and there's a lot of requirements, there are lots of resources out there to help you develop and build your curriculum. You should never feel like you need to do it from scratch. And your program director, even if they're experienced, should know about some of these resources, but they don't need to do it from scratch. There's lots of curriculum available through partner organizations for AAFP, Society of Teachers of Family Medicine, and these are all different organizations, including the ACGME, that provide educational materials guidance for how to develop curriculum in your specialty. Me personally, I allocate out of our department budget funding to send my program director and associate program director to the STFM conference every year. So basically that comes out of our revenues, because it's in order to ensure the success of the program, they need to be able to attend that. You got to have an experienced faculty for the role of program director. They got to be the right fit, people that also believe in your mission and are on board with the mission of the institution, as well as able to meet the requirements of being program director. And last but not least, requirements change. You got to be flexible. The program that you design today may be out of compliance in 3 years. So you have to be able to, have a mechanism to be able to stay flexible with your structure, your curriculum, in order to keep your program accredited. All right. Questions? Yes.
So you mentioned for the CPCA there aren't too many requirements so far.
So for the new rules.
Yeah.
So they still have the rule that they have to have been somebody in an academic leadership position. That's under the new description.
Yeah.
That they need to have had some kind of leadership role within a training program. I believe the rule, it's also still there that they have to have experience for at least 2 years as a core faculty member. I think that's still in there. No, for the PD. And I think they have to be out of practice at least 5 years, out of residency training at least 5 years. For the associate PD, I believe the new, I didn't put it up here, but I believe the new requirements call for at least half time to be allocated to the program. They don't have a lot of those other requirements. You can be an APD the year out of residency, the year after residency. The main thing is that you have time, that 0.5 time that you can allocate to those roles, which under the old model were listed under the program director responsibilities. So there's some pluses and minuses to that. I kind of share your concern, Kiki, about potentially making a less experienced educator be in charge of the nuts and bolts of running the program.
Well, and as a PD, you finally get to that place where you can be considered a PD. Do you really want to have everybody else do the nuts and bolts, or somebody else do the nuts and bolts of the program? I don't know. It just doesn't feel like the job description that they've been groomed for.
Yeah, it's a hard call. I mean, it's almost like it's been kind of retooled to be more kind of like an executive kind of position, as opposed to somebody who's kind of got their hands in it and is, kind of helping to build the program.
Yeah. I think it'll help create a pipeline of PDs.
That's a good thought. That's fair assessment. I think one of the challenges that a lot of programs have, and a lot of us have, that as we try to build new programs, is recruiting people that have been kind of trained or groomed for that. And in family medicine, that's clearly been an issue because there's never even been a model to require APDs. In our program, I just take funding from where I can get it to support 2 APDs. So we have 2 APDs. And it just so turns out, I hadn't even seen the requirements before we did that, but so it turns out that the number of APDs that we have is the number of APDs that will now be required. And because, you realize that the PD does need help in executing their vision for the program. But I don't know how I, as a department head, as a department chair, would feel about, the person that I'm hiring as a PD to kind of lead and have the vision for this training program, having everybody else do the work, right? So, I don't know. I think it needs to kind of pan out as to how that's going to develop. Certainly with pediatrics, internal medicine that have had this requirement, at least the ones at our own site, the program director is intently involved with the operations of the program as much as the associate program directors are. So, but at the same time, they tend to have more time allocated. I don't know I guess we'll hear soon what the allocation requirement for internal medicine PDs is, but typically they have a lot more than 20% time.
Yeah. Now, another issue here is if you have a smaller program, you do a 444 program, I never, ever, ever budgeted an associate program director in a 444 program.
Now you're going to have to.
Now you're going to have to. Now, I guess you would argue good news is overall the time equates out kind of sort of between the program director and the APD, and the fact that I don't think that's a good model isn't relevant. But if I were going in and starting a new program, I'd be arguing with whoever's funding it, doing the budget. We need to have more time of the program director. Let's bump that up. And in addition, we're required to have the associate program director. And now we've got potentially a top-heavy model for a small program.
And then overall, what if that increased the cost of the residency program per year for residents? So I just think of that as it relates to on the ground and the conversations that we have. That'll now be.
If you keep it at 20% and 24 hours a week, that's more than 50 to 60%. If you keep it at 20/60, that's 80% versus 70%. But probably cost-wise, it equates to about the same because an associate program director is paid less than a program director. Okay, so maybe it's equal in cost if you do it that way. But someone like me isn't going to do it that way. You're not going to set it up that way.
I would never set it up that way. I wouldn't put the lion's share of the work on a new grad.
Yeah.
So, I mean, don't get me wrong. I mean, I have some new faculty who are sharp, and they probably would be perfectly capable of taking on that role. But, there's a difference between giving somebody the role because they can do it and giving them the role because they should do it, And I think, especially a new APD, a new graduate, they need that mentorship, right? They need to have some guidance on to how to develop that, that part of their career. And it meets the requirements. You have your 0.2 from the PD and 0.5 from the APD. That equals the 0.7 we have today. But I think you're potentially giving up a little bit in quality of the product that you're getting at the end of the training. But again, that's just my opinion.
Yeah, no, I'm just trying to think through how some of those programs to policy conversations that we have with some of our partners.
Of course.